All right, good afternoon, everybody. Welcome to SEVA VentRounds. Today is February 8th, 2022, and we're gonna get started with our session today. As usual, our disclosure is we will discuss particulars of ventilator modes. We make no endorsement of any particular mode, manufacturer, or company. We really don't care. As long as it ventilates the patient, we will make and say whatever we think about it, and it's our opinion. It doesn't represent Cleveland Clinic. Those are my disclosures, and Rob's disclosures are below that. Let me see if Rob is on. Yes. The ground rules, this is a recorded session, so just mute your microphone. I may call upon you all to comment, but what has worked really well for us is when you just put it on the chat, and we'll take care of it as it's coming through, and I will mention it. If you're a Cleveland Clinic employee, there's CME for this event. All right. So, as the title would said, this is tough. So do we have anybody of our fellows that wants to read this waveform? And for those that are asking to annotate the image, we declined respectfully, but because you would start putting lines on our screen, so that will not. It's not lack of love. Any of our fellows?
Dr. Morales, can you hear me? This is Samid.
Of course I can hear you, Samid. Go for it.
Okay, so I mean, semi-cheatingly, but the control variable appears to be pressure. I can see that the pressure waveform appears to be controlled now. I see breath one. I mean, I'm assuming there's a flow trigger because it's a servo vent, and I can see some color changes, and there is a combination of, like, the first breath, I can see it's machine triggered machine cycle. Then there's a machine triggered machine cycle breath followed by patient triggered breath. So I would call it PCCMV. Now, just going off the mode, it's PRVC. So by default, it should be an adaptive targeting. And there's a variation in tidal volume delivered. Also, the flow appears to vary from breath to breath. So I would agree it would be adaptive, though there's a lot else going on. Inspiratory wise, looking at the load predominantly appears to be resistive. Just looking at the pressure waveform, and expiratory wise, I mean, the time constant is like, I mean, imagine if this is the time bar in seconds. I think it's a long time constant. I'll say expiratory wise, it's resistive as well. For the trigger, I think there's normal triggering. But the second breath, where there's a machine triggered breath followed by a patient triggered breath, I would say this is just early cycling. So, or if you want to put it on Twitter, it will be reverse triggering, but I would call it early cycling. That's just.
So early trigger or early cycle?
Early cycle. I would say early cycle.
Okay.
In terms of inspiration, and if you look at the waveform, there's this first uptick peak, the peak flow that is needed to come over, and then the rest of the flow goes way low. So I'm assuming there's something in the airway that requires higher airflow, either in the circuit or in the airway that requires higher airflow to be overcome. Like the peak airflow is way higher than, you know, like the first or the you know, the first few parts of the inspiration and expiration. I'm not sure if that's work shifting. There is also some oscillations in the expiratory waves. So maybe there is something which is a fluid barrier causing these oscillations. And that's present in expiration as well as in inspiration. So something fixed. Other than that, I think from a work shifting standpoint, I'm not sure if it's just the vent that's varying the amount of pressure supplied for the dynamics, because I don't see much of patient effort. It's difficult to say if there's patient, at least not in expiration, I don't see any patient effort. So I would say no work shifting in expiration, but I'm not sure what's happening. I think this is just the conducting part of the system, which is requiring a higher expiratory flow to overcome the resistance. And then the rest is sort of
normal or work shifting?
I would say normal.
All right. Thank you, Samir. So let's go down this waveform. I think it's very very interesting in many ways, and I'll try to guide you through some of the thought process here. So indeed, it's pressure control. You said it appropriately. Without a doubt, there's the pressure is being controlled, and the flow has nothing of controlled. It's actually just responding to the respiratory characteristics. So pressure control is correct. It's CMB, as you said. I mean, this breath is mandatory because it's triggered by the machine. So it immediately becomes a mandatory breath. This is a mandatory breath, and then this is cycled by the machine, so it's a mandatory breath. So as you said, these are all continuous mandatory ventilation, so all breaths are mandatory. And finally, although you cannot make that distinction very well here based on the waveforms, I left up here in purpose the PRVC so that you would know that it's adaptive. So what that means is that after the end of this breath, the machine will say, well, was the tidal volume at goal or not at goal? So at the target. And then if the answer is no, it will increase the pressure because it didn't reach. And then it will do the same for the next breath and achieve that. Rob, any comments about the tag?
Well, looks good.
All righty. So we all agree with you on this one, Samid. So happy face. All right. So what's the load? So I will just highlight, Samid. I heard you say something that when you saw the pressure waveform, it made you think about resistive load. When you're controlling the pressure, you always look at the flow. The flow is what has the information for the resistive load. And this is a really cool waveform in my mind for many reasons, but I'll try to see how I see it is the pressure gets pressurized, and it's going from a PEEP of 8 to achieve a tidal volume of 500, and the pressure that it's requiring to achieve that on this ventilator is probably close to 30 millimeters of mercury of water, sorry, or more, even more than that. So there's a big delta here of pressure that is being generated from PEEP all the way up, and the difference between this delta, this change in pressure, is gonna determine the height of your peak flow. And so you see the peak flow gets really high up, and then rapidly you see this drop, and then it rises up, and you actually will see it here and here too. You see it not only on the first breath, but you see it on all of them. After the initial rise on peak flow, it drops rapidly, and then it returns up to this kind of shelf that you were describing, this plateau with some oscillations in it. I will point out that if you look at the expiratory flow on this patient, the same thing happens. So you go from expiration, very high peak expiratory flow, and then it returns, it goes almost to baseline, and then it returns up, and there's that oscillation. So what I would interpret of this, rather than inspiratory effort from the patient or other. It's actually that this patient is having the machine pressurized to achieve the inspiratory pressure and overshoot the device, and when it overshoot, it tries to drop the pressure then down, and then up and down, and because there's and so you see those oscillations, and you will see exactly the same here. It goes all the way down and then up and then down and up. So those oscillations is the machine trying to keep the pressure at the goal that it set, the set inspiratory pressure, and you get all of these. And actually, this recoil or this movement up and down of the pressure that occurs, you can see it much better on this side, but it occurred right here too, and here. But you can see that in this one, it didn't cross the zero baseline and it didn't trigger the breath, but it did do that on this one. So creating a false trigger because of the speed on which it's trying to control the pressure. So these artifacts that you're seeing here are just a manifestation of a very high resistive load, and the ventilator trying to correct, to keep the pressure at the set pressure. So in reality, if we didn't have those adjustments of the machine, this should actually look something like that. Roberto?
Yeah, Ibrahim pointed out that the rise time is 0, so there's going to be a higher
Yep.
probability of overshoot with a high impedance system.
Yep.
Also, I think you can appreciate the long time constant better in the expiratory volume curve than in the flow curve, right?
Yep.
It's exaggerated by scale. Also notice that during the time of the high peak expiratory flow, you're only exhaling a very small amount of volume.
Yep.
See that little vertical line in the volume? And that's probably just the charge in the patient circuit coming out, because you have the compliance of the circuit basically in parallel with the compliance of the patient. We think of it as a single compartment model, but it's really not under these situations. And I bet you if you calculated that volume that was exhaled rapidly, it's just the patient circuit times compliance times the change in the airway pressure, somewhere along those lines.
Yeah, and so actually this is a great point. So the peak inspiratory flow rate will be dependent on the speed at which you rise the pressure, right? So if the pressure rises very rapidly to reach the level, it in the setting of high resistances, it will overshoot the pressure that you had set, or it could overshoot, at least on this ventilator, the pressure that you had set, which is what you see here. So completely agree with Ibrahim and you. You can see the time constant, as Rob was pointing, it just continues. It never reaches 0 throughout this period. Actually, it doesn't reach 0. It plateaus as if there was a just very prolonged time constant to get all the air out. So this is, I mean, this is one of those that you're walking through the hallway and you see this, and this is high resistance until proven otherwise. There's a question from Ibrahim. How compliant or elastic are adult circuits?
On the order of 1 to 3 mLs per centimeter water pressure.
Yeah. Very good. So in terms of PV discordance, now you, I think that, Samid, you recognize that in terms of triggering, I actually don't see PMOS here. I am unable to see a clear evidence of PMOS. Perhaps I thought here where I put this little arrow here, if there could be something there. But in general, I think that you have a false trigger here on the, which is exactly this one, what I'm marking A. It's triggering because of the recoil that we discussed of.
A question about that, Eduardo.
Yeah, go ahead.
If you look at the discoloration, it goes from green to white, indicating it thinks that there's a patient signal.
Yep.
But the extent of that white doesn't seem like an awful lot.
I don't know how to grade that, Rob.
Yeah, the length of the white on top of the green line means something, and I was thinking that it meant what the ventilator thinks is the force of the patient trigger signal. So it's not clear to me that this is a false trigger rather than an early trigger with a reverse triggering situation.
Yeah, I could think about that, but I don't see any evidence of any other PMOS anywhere. Actually,
Anywhere else, yeah.
If you see the prior one, this one over here, the one that we don't have complete, you see how it raises, it has the PMOS, and it actually drops the effort there. So I do think, I mean, that's the only one that it's a patient trigger breath that I can, I mean, just based on this, I thought that these could be, I was not entirely sure because you get so close to baseline here. I thought that is likely the cause because actually the way that I thought about it is that the flow ended, and if it had continued, it would look just like that, right?
Yeah.
That's why it's a little bit lower. Yeah. Yeah, so that these items is something that occurs. Actually, the only ventilator that I have seen it's on the Servo U, and it's because of that time constant algorithm that they have for high resistance, in which they're trying to reach that PEEP level. We have talked about that before on our SEVA VentRounds.
Yeah. Plus, the trigger is pretty sensitive, so maybe that does suggest an auto trigger or false trigger.
1.6, so pretty close. I did not see here any PMO, so that's why I couldn't read it as a, and it would not be an early cycle. It would be, because this is a mandatory breath, it would be an early trigger.
Early trigger, right.
Yeah. So I will cross this out. And then I don't see any PMOs during expiration. It looks to me that it's just the oscillations that we described up here. So this is a patient with very high resistive load, at least from what we're seeing. And I would ask the group, as you see this and you see the settings on the ventilator, what does that bring to your mind? Would you change anything? What would be the actions? Just put them on the chat. I would be interested on seeing that. There are some comments while you're typing in. Ariel is saying that he saw something like this and they had to change the sensitivity to avoid auto trigger. Yes, that's a common way to deal with this. Ariel, is to change or increase the threshold for this false trigger. Yeah, so the fellows room is saying that they would decrease the rate. I think that's a good strategy to decrease the amount of auto PEEP and actually allow the patient to exhale longer. So Rishik also mentioned it similarly. Any other comments from the team, Rob?
Nope.
Okay. So very good. There was somebody gonna say something. Okay. Yeah. There's a fellows room also said, please, would this patient even be able to trigger with auto PEEP? Well, he triggered one, Ibrahim, over here. So maybe he is able, but actually, the way that I think about this, and I would like to hear if anybody thinks otherwise, in a patient with obstructive lung disease, the respiratory rate is the minimum expiratory time that the patient will have, or actually the maximum expiratory time that the patient will have. If the patient starts breathing above that, anything that the patient does above that is going to be shorter expiratory time. So when I set the respiratory rate, I'm thinking, well, what's the minimum minute ventilation that this patient can live with, and that he would be able to trigger above that on its own. So allowing permissive hypercapnia as much as you can, and allowing the patient to exhale as much as possible. The fellows say use bronchodilators, consider decreasing the volume too if acid-base gas exchange is okay. So they also said suction the patient if needed. And yeah, all of those are appropriate treatments. You have to go after the cause without a doubt. Hara wants us to check the tube. Absolutely. That's another common thing. You have a patient with COPD, and then you put in this, he has mucus that starts building up, and you can give as much bronchodilator you want. It will not dilate the ET tube. So great point. And there's a question, Rob, what do you think about Ariel's question? He says, is PRBC an adequate mode in this situation?
Well, what's the concern?
I don't know, but would you have anything theoretically against using PRBC in a patient with obstructive lung disease?
No.
Yeah, I would say also that I don't have an issue. Rob, I know you wrote a paper on, well, you have wrote a paper on a lot of things, but you wrote a paper on which mode is better when you have unequal resistances and when you have unequal compliance.
Yeah. I think you have better distribution with volume control with constant flow rather than pressure control.
When
If
there's
you have, that was a paper on a 2-compartmental model with 2 time constants.
Mm-hmm.
And if the goal was to have a more equal distribution of volume, assuming that you had equal distribution of blood flow, and you didn't want to overdistend one versus the other, then as I recall, was volume control gives you a more equal distribution between the 2 different time constants in pressure control. As I recall.
While they read the next one, I'll look for the paper and post the.
I'll look at it. You don't worry about it. I'll check it out.
All right, thank you, Rob. Yeah, and Ariel, I don't have a problem using volume control. Actually, sometimes as long as they recognizing that there's going to be varying resistances throughout the time in patients with severe obstruction, and that you want to guarantee that they will get the minimum gas exchange. So yeah, I think they probably, and we're going to see an example in a second, but a common issue with patients with high resistance is that people panic with the high peak pressures. And the question, and then that leads to other misactions rather than looking at the patient, what's the auto PEEP and what's the plateau pressure rather than the peak pressure, which is only from the resistive component. Very good. So I put one from Angelo. I don't Roncalli. I don't see him on the call, but we always invite him. He is one of our colleagues in Brazil, and he put this one on Twitter that I know a man really got excited about it, and we were discussing. And the cool thing is that it has an ABG on the side, and all the parameters are in universal language, so we can all understand it. This is glucose for those that, so I'll put here U. And that's it. Any of our fellows that wants to read it? Have no fear. Come on. Anybody? Okay. All right. Let me ask, is there, oh, Rishik is here. All right, no fellow?
Unmute from there. Hey,
Oh,
Dr.
there you go.
Mireles, sorry, trying to unmute. Yeah, this is Gaurav from the fellows room.
There you go.
I'll give it a shot. So looks like the tag would be, I see constant flow waveforms, so I would go with VCCMVS, set point.
Okay.
With regards to the load, I'm trying to just kind of get closer to the screen. I'd go with elastic load. For inspiration and expiration, again, I can't see if it's going back to the baseline, but from what I can see it is, so I'd still go with elastic load during inspiration and expiration.
Can you see better now?
Yeah, this is better. Thank you so much.
No problem.
So yeah, the flow is almost going back to the baseline. So I would go with elastic load still in inspiration and expiration.
Okay, keep going. Oh, sorry.
And I don't see any patient triggered breaths. I mean, the 1, 2, 3, 4, 5. I see 6 breaths here. So it looks like the patient's kind of out of the equation. Although the first breath, if we can zoom in again, it looks, the expiratory waveform looks a little bit weird on the first one, on the flow.
Yeah.
If we can zoom in a little bit.
Sorry.
I don't know what happened there.
So I'm gonna make it bigger for all of us. Wait, let me get out of here. This card. I realize, let's crop it really fast so that we can all see it a little bit better. And then, all right.
Okay. Yeah, so breath 2, 3, 4, 5, I don't see any discordance. Breath 1, I don't know what the I see an inspiratory flow pattern. The expiratory flow pattern is, it's not the same as the other breaths. So I don't know what to make of that, to be honest.
So let me give you one hint, and this may help you a little bit. This you see what's happening here. There's a breath, right? In first breath. Yes. And then after the breath, there's no exhalation, right? You see here, this is exhalation. There's no exhalation.
Right.
And then actually they release the expiratory pause, the inspiratory pause. There's exhalation, and then it continues to go. So what happened here?
Oh, did they do an inspiratory hold?
Yes, this is an inspiratory hold.
Okay.
This changed your assessment of the load.
So let's see. So looks like the plateau pressure is less than 20.
Yes.
Yeah, so maybe it's more resistive than elastic, the load.
So this is the peak pressure, and the plateau is all the way down here.
Yeah, it is definitely resistive then.
Right.
And then for exhalation, again, I think we need to zoom in a little bit, but yeah, I think I'm squinting my eyes, but I'm just gonna go with resistive too, with the exhalation.
Yeah. Do you see any patient ventilator any patient activity now?
No, I really don't.
Okay, excellent. Very good, Gaurav. I appreciate it. So yes, it's absolutely volume control. You read this as it was, and actually I put it down here just for you to be able to see it. This ventilator is in Portuguese, and so what you'll have some terms that will use that you're not used to, but this is the same PVA 40 that we use over here. All the breaths are CMB mandatory. There's no evidence of PMOS, so they are triggered by the machine and cycled by the machine. And
Yeah.
so, and it's set point. That's the only variable here. You set all you set the tidal volume, you set the flow, and you set the type of waveform. And then, as you read it correctly, this is the peak pressure, and this is the plateau pressure. And actually, this is a good example about what we talked before about how that difference between the peak and the expiration, and how that determines your peak expiratory flow. So look at how here the pressure at the end of the breath is down here. That's the plateau. And when they release the expiratory flow, even though it's the same tidal volume that was in here before, it just accelerates this amount instead of as much as it was the other peak flows. You cannot see it, and this is actually one of the things that it's called sabotage, is that the way that this is set right now, you have a gain that goes from 0 to 120 liters per minute. So being able to see it not reaching 0 is very hard for your eyes.
Very hard.
Which is what's happening to you. And you perhaps can now see those oscillations that I showed on the other one about the flow coming back and then trying to go back to the level of the pressure, and that's what that little oscillation you see right here.
Mm-hmm.
All right, Rob, thoughts?
I wasn't paying attention. I just went and found the reference there.
Oh, wonderful. All righty. Excellent. So any comments here? So Aman, you are you on the line? Then
Yeah, I'm here.
Aman, I mean, you commented about this, and one of the questions that was posed was, well, the time that it takes to go from here to here, to the plateau, right? So theoretically, the moment that you stop the flow, technically the pressure should go down as fast as it can and be here. But you pointed out that there was this delay on how much it took to get there. Do you want to comment on it, please?
Yeah, so my thinking in this particular case was that the reason for that is that at the instant where the inspiratory pause is applied, in other words, where the flow goes down to 0 and the inspiratory valve closes, at that very instant, the airway pressure is 95. It's obviously not typical. So it's not typical, obviously. So at that instant, the airway pressure is 95, and the situation is such that 95 is in the proximal airways and the circuit, proximal to the, I'm guessing the source of resistance, which we haven't disclosed at this point, but I knew at that point. So I think the reason, so what happens after that is in the next few milliseconds, the proximal airways in the circuit decompresses past the point of resistance, and then basically the gas is transferred from the proximal part of the system, proximal to the obstruction, to the distal part of the system. The few cc's of air squeezed from the proximal airways into the distal part of the system and the lungs, and it takes a few milliseconds because that resistance is so high.
Yeah, you mean if the patient was biting on the tube or something like that?
Similar.
And in general, there's two reasons for that exponential decay down to the plateau pressure. In the literature, they say one is stress relaxation in the tissues of the lungs, and the other is penduloff, which is basically what you're saying. So you can have penduloff between two lung units, or penduloff between the patient circuit and the patient, right?
Yeah, so the different
Yep.
time constants, different time constants in the lung and moving air from one region to the other.
Yeah.
One of the questions, Rob, that they're having, and you're really good at explaining this, is why the peak flow for the same tidal volume is so small here versus this one over here.
Well,
in-
because you have to think of the things that are contributing to the peak flow. So when the first one is small, because what's contributing to it is just the plateau pressure minus the PEEP. So that's the driving pressure for expiratory flow. Whereas on the next breath, the driving pressure is the peak pressure minus the PEEP. So you're going to have a higher flow, but there's a very small volume that's being exhaled during that very short period of time. So you have to ask yourself, what is the driving pressure that causes the peak expiratory flow? So if you have a plateau, an inspiratory hold, it's the plateau pressure minus the end expiratory pressure, not total P, but the airway pressure. That's your driving pressure. And in the next breath, the pressure drops all the way from peak down to PEEP. That's your driving pressure. So whatever comes out is whatever volume is available to do that.
So just remember the driving pressure is equal to the or proportional to the peak expiratory flow.
Yeah.
Yeah, I can zoom. There you go. All right. I will just quote what Rob wrote in 1994. Different compliances.
Before all you guys are born, right?
Yeah. For different compliances, but equal resistances, volume control gives more uniform volume distribution. For equal compliances, but different resistances, then pressure control gives more uniform volume distribution. Any comments about that, Rob?
You have to think about it. It's complicated.
Yeah. And so the paper does the whole derivation of this. So
Yeah.
Very good.
And again, that was just for a 2-compartmental lung with 2 different time constants. And the time constant can vary, obviously, by either having different resistances or different compliances, with the other thing being equal.
Can I add,
go ahead.
Just a little. So I just want to kind of clarify. So are we kind of saying that, especially in the rest of the breaths, the initial peak flow is because of decompression of the circuit and the airways?
Yeah.
So in other words, like 2 time constants. Yeah.
Yeah.
Because that'll make sense if you're saying the driving pressure for that is airway pressure minus PEEP. Because that would make sense, because that's coming from the circuit and the proximal airways. If we are talking about driving pressure from the lung parenchyma, then it should be plateau minus PEEP, which probably is the second
right.
the time
so
constant.
Exactly. It's hard to see because of the scale, like Eduardo said, but what you have here is a double time constant, a double exponential, because we keep trying to simplify everything by saying this whole system is a single time constant, a single resistance and a single compliance. But under these extreme circumstances, you don't. You have a patient circuit that has a compliance and a resistance, and in a respiratory system there's a compliance and a resistance. And so you see these weird effects, and you have to take that into account.
Very good. Any other comments? So, and this is a common issue. So you can see that the patient here has enough oxygen to donate to another country. The CO2 is elevated, but the pH actually is not that bad. I mean, in this group of patients, we tolerate actually pH around 715 and above.
Wow.
And so the question is, how do you improve or optimize gas exchange on this patient? Do you need to decrease the rate to allow the auto PEEP to decrease and go down, and that way improve the ventilation in the lung, increase the tidal volume? I mean, we don't know the size of this patient, but this may be close to dead space in somebody with COPD or asthma. So Yeah, these are challenging because the natural reflex is to increase the respiratory rate. That's the natural reflex of the team. Very good. All righty. Let's see another one. This one is it's a bonus. Anybody wants to read this one? Good job, Garb. It was a tricky one. Any of the fellows wants to jump in?
I can try if nobody is. This is Samir here, Dr. Morales.
Go for it, Samit.
So, reviewing the waveforms here, I see that there is no control on the pressure waveform, on the flow waveform, but the pressure seems to be the machine seems to be trying to control the pressure. So I would say the control variable is pressure because the flow seems imperfect. I don't see any, or correct me if I'm wrong, I don't see any color change. So all of these breaths appear to be machine triggered and machine cycled.
There is color change here, and you have also a drop.
At least on my screen, it doesn't appear to be so.
Yeah.
But I would say still they're cycled by the machine, so they're mandatory breaths. So CMV would be. And targeting scheme, I don't know. There appears to be breath to breath variation in pressure. Like it doesn't seem to be very constant. I don't know. Could be adaptive. Also, I'm also cheating a little bit, but seeing that you have set a tidal volume at the bottom, so I don't know. Yeah, so I think it's PCCMVA and I think it's PRVC on a servo U. In terms of load, I think we're seeing sort of something similar, these peak inspiratory spikes due to impedance. But the interesting thing is in at least the central breath that I can see, there appears to be the flow waveform appears to go fairly high and then not showing that plateau, but the second breath immediately after shows a plateau. But I would say inspiratory is still resistive load. The peak inspiratory flow is fairly high. So I would call inspiratory load being resistive. From a time constant standpoint, the expiration seems fairly prolonged. I think there is an expiratory resistive load as well. Now, can you help me sort of clarify where are the triggered breaths? Are all the breaths patient triggered? Because I have no color expression on my screen.
All of them.
I think there is a pressure trigger. That's what's happening. And this one, I mean, I'm more focused on the central breath from a trigger standpoint. I mean, patient triggered, and then the rate seems to be 14. I mean, I don't see any trigger abnormalities. I think it's normal triggered. All of them. I mean, there's a negative, like at least there's a negative pressure, or there's a dip in the pressure when the breath is being triggered. From an inspiration standpoint, I don't see any work shifting. I don't see PMUS. Cycle wise, again, I might bite my words later, but that's what I feel like this is early cycling, as now we can discern that there is patient effort that is leading to the trigger. So maybe this is early cycling. But yeah, I am not sure. Expiration wise, I think there's just high resistance. I don't see any active patient effort, so I would say normal.
Thank you, Samit. Valiant effort. It's a tough one to see, and especially I blinded it here, but it was intentional. some people are putting PCIMB as a potential. So this is a really interesting phenomenon that we see, and it's a little challenging to understand, but I'll try to walk you through it. There's some things that I don't understand about this, but I will put you what I do know. So indeed, this is pressure control, as you pointed out. The pressure is being controlled through the breath. The flow is not controlled at all. The breaths are mandatory, indeed. Actually, this breath over here, you can see that it's time cycled, right? We set the inspiratory time, so it got triggered by the patient, and it got cycled by the machine. This breath over here also was triggered by the patient. You can see the dip on pressure, the same as over here, and the changing color is barely visible, but it's there. But you can see the same thing on the next breath and on the prior breath. There's a little bit of a dip on the pressure. However, this breath is cycled off in spite of there being PMOS. So the PMOS on this patient goes from here all the way to here. That's the length of PMOS of the patient. And so, but the breath got cycled early, and then you have this one. So there's two different I times. This breath over here did not get cycled by time. It got cycled by volume. It got cycled by volume. And that's a secretive secret from these ventilators. And when you are on an adaptive mode, as you recognized, if the total volume that the patient gets is 1.5 times the size of the breath, the machine will cycle the breath, and that's what you saw there. It's cycled based on volume, and so it's a machine cycled breath, not a patient cycled breath. So still all the breaths are mandatory, so it's CMB. The difference is that it triggered a algorithm in the ventilator that said, oh, that's too much, but because the patient continued to do enough effort, his PMOS, his neural time was longer than what he got, then he triggered another breath. And actually, you can see that has been happening before and in the next breath. And so during inspiration, it's really hard for me to see what's the load on this. So let me, before I go to the load. So the question is, well, how do you know this is adaptive? And just looking at this waveform, it's a little bit hard for me to say so. But this is the way that this mode behaves when it does this. I don't know. This is the part I don't know why the second breath is higher than the first breath in terms of pressure. It doesn't make sense to me, but there's part of the algorithm that the Servo U engineers put in, and so that's how that pathway looks. Rob?
There's nothing about this documented in the manual that I can find. And the only other thing is the way you know that this is adaptive targeting is because there's a set tidal volume at the bottom.
Yes. Excellent, Rob. In terms of load, during inspiration, Samir, because there's PMOS, it's impossible for me to see what's the load by looking at the flow. There's no decay time enough, and the next breath there was evidence of PMOS, and it went essentially down within milliseconds. So if anything, it would look elastic, at least for the second breath. But I would say that the majority of what I see here is PMOS on this patient. And then during exhalation, if there's some hints here that make me think that this may be there could be resistance, but I think that there is PMOS, and is the fact that he exhaled, and then you see this increase on flow afterwards. You see how it went down and then it comes up, which means that there is active exhalation from this individual. And the waveform over here also makes me suspect that, but you could be very well right that there is resistance. I'm just suspicious that this may be more PMOS than what we think in the setting of a lot of volume that the patient has. It has this 600 plus this amount. Actually, if you see the amount that the patient exhaled at the last breath, it was 815 instead of 370. That's how much that human being put inside their little body. And so actually you can see that it's 13.3 mLs per kilo instead of the 370 that the patient was supposed to get. So when I see trigger, I agree with you 100%. This is normal trigger, normal trigger, normal trigger. In inspiration, I think that there is work shifting, Samir, just because I know that there is work here, but it's not severe and it's not dropping, but there's some work shifting. I think that you're right on that this is an early cycle in these circumstances. So it's a patient breath. The PMOS goes for long enough and it triggers another breath. And I think that in terms of expiration, you're dealing with expiratory work for the reasons that I pointed out here. Roberto?
What did you do for this guy?
So I'll open it up to the team. What do you guys would do? Anybody? So in this patient, I'll tell you. Yeah, thank you, Ariel. Exactly. So one of the challenges with the exactly, Samid, what depends on the goal. Depends on the goal. So there is no mode. The mode that can help do this was to change them from a mode from PRVC, which was the mode. We tried volume support. The same happened. Obviously, it's the same algorithm, just without. Then we tried pressure support, and with pressure support, we were having very large tidal volumes. And so the question then becomes, okay, I can make him synchronous without having this stuff happening, but what is your goal? If your goal is safety, then you may be more inclined to sedation and paralysis if needed. Yeah, and if your goal is comfort, then your brain activity should be moving towards, well, am I going to extubate this patient? Do I take out the pain or whatnot? But you can notice down here what were the settings for these patients. So the patient had a long protective tidal volume, had a high PEEP, and he was on 100% FiO2. So just by looking at that, the goal would be safety. And under those circumstances, there is no mode, no good mode that will save you from this circumstance. You would be fighting the patient to death.
Just a COVID patient?
It's possible. Most likely, the answer is yes. I just put this for you, Gaurav, and the fellows. You can see this is a real close-up of one of those patients. I didn't show this case, but this is the baseline, this one over here, and you can see how close it is from the baseline, and the flow continues. And when I increased the gain, I went to a gain of 10. So I made it very, you can see how far away it was from reality. So this is how it looked when I was walking by. This is how it looked when you change the gain. All right. With that, we finish. Here's the CME for those that want CME. And again, thank you very much for joining. Send us your waveforms. We really love looking at them, and we'll bring them up on this case to discuss. There's always something to learn. If there's any questions, we'll attend to them. Thank you.